thank you to the RCPA for an opportunity to present the recently launched top 5 recommendations for low-value transfusion practices. But most importantly, thank you for all joining me today. I need everyone on the call to make every drop count, to make sure that we value the use of every blood product that's prescribed for transfusion. So to help set the scene, I want to take you through some of the practices and strategies that are currently employed to try to make sure we use every drop appropriately when it comes to the precious and valuable resources of blood. And I'm sure no one on the call is surprised by me starting with a conversation about patient blood management, or PBM. PBM has been introduced to the medical community for almost 2 decades, and it was first mentioned in the late 1990s and becoming publicly aware from the early 2000s. And I've put up one of the early schemas of how the movement of PBM was initially started, with the 3 pillars of PBM. And you may be familiar with those pillars of optimizing red cell mass, minimizing blood loss, and managing anemia. And these pillars of patient blood management crossed multiple sections of patient care, but it was predominantly focused around those patients in the perioperative setting. There was times to identify and treat patients with anemia in the pre-op setting, and also was also appropriate in the post-operative setting as well. Pillar 2, talking about minimizing blood loss, was focused in the intraoperative setting for surgeons and anaesthetists, with meticulous surgical procedures and also advances in surgical techniques, but also had an opportunity for anaesthetists to use strategies such as cell salvage to maximize the return of that patient's blood loss to the patient. But it also used non-additional approaches to trying to minimize blood loss, such as making sure the patient stayed warm, using appropriate positioning of patients. And then finally, pillar 3 was talking about how we managed anemia. And this strategy was really placed in the realms of evidence-based medicine, or evidence-based transfusion thresholds that could help clinicians decide if a patient needed transfusion. And how many health services around the world had different approaches of how to introduce these strategies into current care. And beginning in 2011, the National Blood Authority introduced their patient blood management guidelines. And these are there were 6 modules that were published from 2011 through to 2016. And they were created by subject matter experts based on the evidence available at that time. And they made clinical recommendations for the safe and appropriate use of blood and blood products in different clinical settings, be them perioperative, medical, critical care, or for those patients with critical bleeding requiring major hemorrhage protocol activation, or obstetrics, maternity or neonatal and pediatrics. However, over the next decade, we have seen even further developments and improved sophistication in the definition of PBM. It's really moved towards a patient-focused, systematic approach to improving patients' care. And importantly, it's evidence-based, but none of these can happen without patients being in the centre of their care. And so ultimately, the PBM strategies have really been focused around the patient being pivotal in making informed decisions, and ultimately healthcare professionals trying to manage and preserve the patient's own blood. And the overarching strategy of why we want to achieve these approaches is to promote patient health, safety and empowerment. This recent publication, recent definition update came through SABM in August 2021. And you can see that the 3 pillars of patient blood management have transformed to 4 pillars, with patient outcomes as that central keystone to successful patient care. Again, we have the managing anemia as a cornerstone, but they've now changed minimizing blood loss into optimizing coagulation. They've given a whole pillar to patient-centered decision-making, and a whole pillar to interdisciplinary blood conservation modalities that can include things such as pharmacological agents, as mentioned, that I didn't mention in the previous slide. So I wanted to ask, so we've had a strategy of patient blood management, or approaches for patient blood management around for nearly 2 decades. But do we have evidence that it's working? We know the focus of patient blood management strategies are to ultimately improve patient care, but are we seeing a reduction in transfusion patterns or changes in clinical practice? And I'll draw your attention to this article that was published in Transfusion in 2017. One of the haematologists Western Australia, Dr Leahy and colleagues published some data looking at exactly this issue. So I'll draw your attention to the red columns here. These are the number of red cell units transfused. And as I mentioned before, PBM has been in its infancy in the early 2000s. And this graph goes from 2003 up to 2016. But you can see here, and I'll draw your attention to the financial year 2008 to 2009. This was when the Western Australian Department of Health introduced a system-wide strategy to implement patient blood management within a state. And you can see that there has been a reduction in transfusion issues of red cells for transfusion over the ensuing almost decade. And this is despite increasing the population of Western Australia. But this paper goes on to also discuss transfusion rates in Western Australia versus the rest of Australia. So again, I'll draw your attention to the red graph, columns on this throughout this graph, and you can see that if I draw your attention to 2015 to 2016, you can see that 19 units of red cells were issued per 1,000 population in Western Australia versus 28 units of red cells issued per 1,000 population in the rest of Australia, excluding Western Australia. So this is interesting because we can see, even though if you ask clinicians about patient blood management, they will say, yes, we do it, yes, we practice it. But there does seem to be, at least 5 years ago, a bit of opportunity for variation in practice and opportunities to improve that strategy further. So with that in mind, ANZSBT had talked about how can we optimise the demand or the clinical use for blood products. And ANZSBT really kicked into gear to complete and advertise the Evolve top 5 recommendations for low-value transfusion practices over the last 18 months. And this was really driven by critical shortages of the blood supply to levels that we have not seen before, or I have not seen before as a haematologist. And many in the audience might have seen called out by the Australian Red Cross Lifeblood asking for donors. They've had unprecedented shortages of supplies due to donors not being able to donate as if they usually would. And I thank the communication team at the Australian Red Cross Lifeblood for sharing some of these comms with me on this slide. So you can see here that they've done a call out to donors that we've had unprecedented times for everyone. They've seen unfortunate coincidences of yet another natural disaster, that was the floods in the eastern states, a new spike of COVID infections, and the worst flu season that Australia had seen in 5 years. And they have estimated that about 20%, or 1 in 5 of Australian donors, were unable to donate in any given day. And so just to take a step back, we've got about 500,000 blood donors in Australia. And at times in earlier this year, in say February or March of this year, we had national-wide COVID infection rates of more than 100 to 150,000 people infected with COVID. And those people were obviously, and those family members were required to isolate as a part of public health strategies. And so another message that was sent by the Lifeblood and communication team was that more than 4,500 appointments were not attended every day. And even for those donors who did attend, only 1 in 2 resulted in a successful donation. So whilst we've had patient blood management strategies around for decades, we've been faced with unprecedented shortages of potential blood supply due to donors being impacted by natural disasters and pandemic infections. And so with that, ANZSBT thought it was time to have another push, release new guidelines to really make sure that clinicians can be actively engaged in the decision-making they undertake when it comes to blood and blood products. So I'd just like to take a step back to tell you about Evolve. So some people in the audience are very comfortable with what Evolve is, and some people might know about the concepts of choosing wisely, but where do they really fit, and how are they fitting in with these top 5 recommendations? So Evolve is a flagship initiative led by physicians and the RCPA to drive high-value, high-quality care in Australia and New Zealand. The RCPA through Evolve is a co-founding member of the Choosing Wisely campaign, and all of the Evolve top 5 recommendations form part of the Choosing Wisely campaign. Evolve will work with specialties, as you'll see over the coming slides, to identify their top 5 clinical practices that they decide are either overused, provide little or no benefit, or can potentially cause harm to patients, and they are the focus of the recommendations. So through the development of the top 5 recommendations for low-value healthcare in a particular area, that will enable clinicians to phase out low-value tests, phase out treatments and procedures that do not offer benefit to patients, enhance patient safety and quality within the healthcare system, and ultimately provide high-value healthcare that is evidence-based. But as stewards of the healthcare system, we can use limited resources appropriately and wisely, minimise our carbon footprint within the healthcare system, and minimise the waste associated with ineffective healthcare services. So I'd just like to take you through this 6-step process of how the Evolve team helped us walk through the top 5 recommendations. I'll start at number 1, or identifying a problem. And some people in the audience might recognise that this is really consistent with a clinical practice improvement methodology. So we started with diagnosing the problem, or identifying an area that or a list of areas that we thought were low value healthcare. These processes should be rigorous, it should be peer reviewed, and ultimately led by experts within a clinical field. This list needed to be, and their opinions and recommendations needed to be evidence-based, and they needed to be consulted broadly, transparently, and widely. So if we move to step 2, or refining, the society would refine the list of low-value healthcare practices or procedures, and then those wide, broad lists would be funneled down to just 5 priority areas of practice. And the way that the working groups would decide what the top 5 priority areas were is they would always ask themselves these guiding questions. Do we believe that the practice is overused? Do we believe there's little or no benefit for our patients? And is there evidence or suggestion that these patients may undergo harm as a result of this intervention? And then we finally ask, if the answer is yes to the above qualifying or guiding questions, do we think it happens enough to actually make a difference if we stopped people doing that practice? Once we had refined our list of top recommendations to just 5, we would undertake a literature review to provide recommendations that were evidence-based. Then those evidence-based low-value recommendations would be shared with the Choosing Wisely campaign and to be disseminated widely. And I had an opportunity to present ANZSBT's top 5 recommendations at the Choosing Wisely National Conference earlier this year. And then finally, we come up to the implementation phase, and that's where we're in today. The physicians will leave the implementation of the recommendations. And finally, as part of every good audit cycle or quality improvement cycle, we have a scheduled in time for review to make sure that the top 5 recommendations are current and still relevant to publication. So now we know who Evolve is. Well, I'd like to take just a few minutes to tell you about who ANZSBT is. And ANZSBT is the Australian and New Zealand Society of Blood Transfusion. We're a binational subspecialty society of about 350 members that are made up of doctors, nurses, and scientists who all work within the field of transfusion. Our mission statement is to define and promote best practice in clinical and laboratory transfusion medicine, to engage with stakeholders in all areas of transfusion through communication, representation, and advocacy, and to promote and support education and research. And to deliver this, our aims of our society currently are to advance knowledge in blood transfusion and transfusion medicine, promote improved standards of transfusion practice, collaborate with international and regional societies interested in blood, promote interest in research into blood transfusion and related topics, and also, and key, is the development of guidelines to ensure that we have safe transfusion practice. And I'd just like to take a few moments to show you some of our guidelines that have been published in the last few years that you may not realise that you've been following the ANZSBT guidelines. So these are 3 examples of guidelines that have been created by a subcommittee within ANZSBT called the Clinical Practice Improvement Committee. These guidelines are to which hospitals are accredited to. So when you go through hospital accreditation, you need to adhere to guidelines. And these are some of the guidelines that you'd be adhered to. So many of you, without knowing, are adhering to the administration of blood product guidelines. And recently, we've published 2 new guidelines at the end of last year, because there is an area of need. So with increasing diversity in the way we practice healthcare and the increased number of potential nurse practitioners who are allowed to prescribe blood and blood product as part of their scope, they had no framework for governance, safety and training. And so we provided a guideline for them to do that. And then recently we've also released guidelines about how we can use electronic medical records for prescribing and administration of blood and blood products. Again, this was an area in need without the necessary guidelines to provide safe and appropriate transfusion practice. So our guidelines don't just cover clinical transfusion, they also cover laboratory processes as well. And just as our clinical guidelines helped maintain safe and appropriate transfusion from an accreditation perspective, our laboratory guidelines offer the same structure for accrediting bodies, be it NATA, NATA or other accreditation organisations, because they provide translation or a roadmap to the NPAC guidelines. Most famous, or what we're most well known for, is the guideline for transfusion and immunohaematology laboratory practice, but we've also recently released guidelines for the laboratory estimation of fetal maternal haemorrhage. And finally, we've also have out for public consultation at the moment guidelines for the prevention of transfusion-associated graft versus host disease. These guidelines are open for feedback until the 31st of August, and I encourage everyone on the call to download those guidelines and provide feedback. So to wrap up how the two collaborators met, I'll finish by telling you the story of how ANZSBT and Evolve created our top 5 recommendation. So several years ago, the president at the time, Dr. James Daly, agreed to collaborate with the RCPA through Evolve to create top 5 recommendations. The previous Clinical Practice Improvement Committee sent a survey and engaged with ANZSBT members to ask them what they believed was Australia's and New Zealand's leading low-value transfusion practices that needed to be addressed and advocated for change. And then they began the initial process of literature review. And more recently, since we've had significant issues with our blood supply due to COVID and natural disasters, the Education Standing Committee has completed the literature review and launched the recommendation in March of this year, which I'm very pleased to present you those top 5 recommendations for the next 15 or 20 minutes of today's presentation. So let's go through the recommendations, all 5 of the recommendations step by step. So recommendation 1 is to not use perioperative transfusion for otherwise reversible anemia prior to elective surgery. Recommendation 2 is do not transfuse red blood cells for iron deficiency where there is no hemodynamic instability. Recommendation number 3, do not transfuse more units of blood than necessary. Recommendation 4, do not order a group and cross-match when a group and antibody screen would be appropriate. And recommendation 5, do not transfuse standard doses of FFP or fresh frozen plasma to correct a mildly elevated INR prior to procedure. So for those on the call, many will recognise there's aspects of these recommendations they may have seen in other international Choosing Wisely recommendations and programs. However, these were the top 5 that ANZSBT members felt needed the most changing because it represented the most frequent and most significant low-value transfusion practices across Australia and New Zealand. So if we go through each recommendation and some of the literature behind it, we'll start with recommendation number 1, which is do not use perioperative transfusion for otherwise reversible anemia prior to elective surgery. Over the last several decades, we've recognised that patients who enter into surgery, elective surgery, who are anemic are more likely to have adverse outcomes. And there appeared to be an association with anemia with increased morbidity, increased mortality, increased ICU and hospital length of stay. And they found that an independent risk factor for these adverse events was also associated with a perioperative transfusion of red blood cells. So a lot of the patient blood management strategies had been focused around identification and management of anemia prior to surgery. And so our recommendation is consistent with that we shouldn't transfuse in the perioperative setting to prevent, because we don't believe that that will improve patient outcomes, and there's no evidence to say that there is benefit, and there may actually be signals for harm in that setting. So I've just selected 8 references here, or 8 documents that we looked through to help come to this recommendation. You can see here that these studies were really looking at patients who had predominantly malignancies, and was looking at the effect of perioperative transfusion on the outcomes of these patients. You can see some patients had esophageal, colorectal, gastric cancer, renal cancer, but they also had a large study in 2011 that was looking at all non-cardiac surgery. There was also some study in paediatric cancer patients as well. And all of those studies did suggest there was an independent harm associated with the use of red cell transfusion in the perioperative setting. So we'll move to recommendation number 2. Recommendation 2 is to not transfuse red cells for iron deficiency. And the caveat is when there's no hemodynamic stability. So the real take-home message of recommendation number 2 is if a patient has a hematinic deficiency leading to their anemia, that hematinic, or that be iron, B12 or folate, should be replaced to correct a patient's anemia. In the very, very, very rare case where a patient actually is unable to maintain their cardiovascular system to the point where they're not got end organ hypoxia, then if they do need a blood transfusion, then it should be the minimal number of blood units transfused, that is 1, and then that patient should be appropriately managed with either iron, B12 or folate replacement rather than recurrent units of blood transfusion. We also would advocate for, if a patient did have severe iron deficiency anemia and did happen to need 1 unit of red blood cells for hemodynamic compromise, they should also be managed with iron post-event as well, to make sure we've actually managed the initial cause of their severe anemia. But most importantly, we would advocate for that patient to be appropriately investigated for why they had such profound deficiencies in those hematinics, and they need to be managed as appropriately as part of appropriate and patient and best practice patient care. I just wanted to share some of the evidence behind those recommendations. This is a recommendation that's seen in several other Choosing Wisely campaigns. But again, this was something that the Australian and New Zealand audience thought was particularly important. One of the recent publications that many on the call will know about is the PREVENT study that looked at the preoperative administration of intravenous iron prior to major abdominal surgery for patients who were anemic at randomization. This study showed that intravenous iron given between 1 and 42 days prior to major abdominal surgery did not prevent the primary outcome of either the need for transfusion or the risk of the patient dying as a result. However, there was a sub-study that's currently in the literature, currently being published at the moment, that really just said that it didn't matter if the patient was iron deficient, or be it an absolute iron deficiency or a functional iron deficiency, there still wasn't any change in the primary outcomes. However, if you looked at those patients who were iron deficient and did receive intravenous iron, they did have a significant increase in their hemoglobin approximately 2 weeks post administration of the IV iron. So the PREVENT study didn't say that you shouldn't treat iron deficiency in the preoperative setting. It just said that it didn't prevent blood transfusion or death as a primary outcome. And so as a result, many in the perioperative setting is now looking at when is the best time to administer iron to these patients undergoing surgery. And there's a study that's being set up now looking at the post-operative administration of iron to see if there was improvements in patient outcomes. But you can see here from multiple other studies, including Cochrane reviews and recommendations from the patient blood management groups, that they advocate for the recognition and the management of patients with iron deficiency with iron in multiple formats. And the mode of how you replace that iron would be dependent on the patient's clinical situation and also their underlying diseases and the tolerance of those therapies available to them. So recommendation number 3 is not to transfuse more units of red cells than necessary. And this really comes down to evidence-based transfusion triggers. And over the last 20 or so years, maybe closer to 25 years, we've had increasing evidence that a restrictive transfusion strategy is non-inferior and possibly even superior in certain patient populations than a liberal transfusion strategy. And the pivotal or the landmark study that was released in 1999 was looking at restrictive thresholds in patients in the critical care setting in ICU, and found that there was actually a subgroup of patients, the majority of patients actually did better with restrictive transfusion strategy. And so our recommendation is consistent with the National Blood Authority's guidelines, the AABB choosing wisely, the Canadian choosing wisely, and the ASH recommendations that restrictive transfusion strategies should be used for the majority of hospitalised patients who are stable. However, if we do need to transfuse, then a single unit should be administered, and then we stop and reassess for signs of benefit, and hopefully no harm has occurred as a result of that. So single unit should be, transfusion should be considered the standard of care, and most importantly, patients should be reassessed for their response to that transfusion. The second part of recommendation 3 that says not to transfuse more units than necessary is really about the intrinsic risk of a blood transfusion. So red cells, or any blood that's transfused, is basically a liquid transplant. It's an allogeneic transplant of viable tissue. And so there is a risk associated with every transfusion, and that risk will increase with the number of transfusions that are administered. The most common reactions are usually mild and self-limiting, such as allergic reactions that can occur 1 in 100 transfusions, and also the risk of transfusion-associated circulatory overload. Again, rates of about 1 in 100. However, the harm or morbidity associated with that would depend on the patient's underlying comorbidities. And so the harm associated could be different based on the patient's clinical presentations. There's also a risk of febrile reactions and even worse, hemolytic reactions, as well as the rare events of transfusion-transmitted infections. However, I just wanted to touch on the risk of patients becoming alloimmunized or developing antibodies as a result of transfusions. There's certain patient populations where this has a significant impact, and I see that on a daily basis working in an obstetric hospital or a high-risk maternal-fetal medicine unit, where up to between 9 and 12% of all of our women are alloimmunized, and so obviously has significant harm to mother and baby because of the manifestations of clinically significant hemolytic disease of the fetus and newborn. But the other group of patients that are really affected by alloimmunization are those patients who have recurrent transfusion strategies. And whilst the timing and transfusion strategies for these are published in many international guidelines, these patients still potentially have alloimmunization rates between 30 and 50%. And the groups of patients I'm talking about are those patients with thalassemia or sickle cell disease. And so they have significant impacts on the healthcare costs associated with the management of these patients if they do become alloimmunized. So again, we want the minimum number of units transfused, and there needs to be clear indication of why we need to give those transfusions when we do. And again, these are just some of the publications of the landmark studies looking at the restrictive versus liberal transfusion strategies in multiple clinical settings, including cardiac surgery, ICU, non-varicose upper GI bleeding, sepsis, and also some pediatric studies as well. Recommendation number 4. This is one of the more unique recommendations to ANZSBT. The Canadian Choosing Wisely campaign mentioned this, but this was something as a society that covered both clinical and laboratory transfusion practice we thought had a significant impact on the cost associated to the healthcare system. So recommendation number 4 is not to order a group and cross-match when a group and screen would be appropriate. And so just to clarify, when somebody has a group and antibody screen, we determine their ABO and RH group, and we also make sure there's no red cell antibodies in the plasma. And usually we would stop that process there. That information would be stored in an electronic information system or a laboratory information system, and we could potentially issue blood on those results for up to 3 months, depending on the clinical situation. So with that explanation, that really explains that first sentence there, that laboratories that have a modern on-site laboratory can issue compatible blood within minutes, just simply doing a group and screen. However, a group and cross-match is we still do the group and screen, but the cross-match means that we need to allocate blood specifically for a patient. So there is extra steps, extra costs, and also makes complexity with what we do with that unit. So what that would mean was we'd find the patient's blood group, make sure they had no antibodies, we would go and select units of blood compatible for that patient. We'd issue those units to the patient. We would then transport the blood to wherever that patient was going to be it a remote blood fridge or a different site, or simply allocate it within our laboratory. But once those units are allocated, we cannot use those units for another patient. So ultimately, that means we're going to increase our inventory levels. We're potentially going to increase the age of the units when they're actually transfused. It can lead to increased wastage due to the complexity associated with additional steps, and it definitely costs more from a time and workload perspective doing a group and cross-match versus a group and screen. And if you think about a purely financial perspective, it costs about $40 to do a group and antibody screen, but it costs about $110 to do a group and cross-match. And if that being said, if you do have a patient who have antibodies, of course, provide, and they are at a significant risk of bleeding, then yes, a group and cross-match is absolutely an appropriate strategy. However, if you don't have an on-site laboratory and there is surgery happening at your organisation, we would recommend the use of a strategy known as the MS-BOSS, or the maximum surgical blood ordering schedule. Again, this should be evidence-based and reviewed every 1 to 2 years to make sure you have appropriate blood ordering based on the need at your institution. And so just some nice evidence around why that strategy is recommended. And that's currently recommended also in the ANZSBT guidelines for appropriate inventory management, as to the National Blood Authority's recommendations for optimum inventory management. And finally, recommendation number 5 is not to transfuse standard doses of FFP for mildly elevated INRs prior to a procedure. This recommendation actually resulted in the most amount of feedback from other societies when we asked them for their feedback of our recommendations. And the key message behind our recommendations is somebody's INR does not determine someone's risk of bleeding in a procedure. So we are advocating for patients to have an appropriate and comprehensive bleeding risk assessment, be it a bleeding history, reviewing medications, and we don't want people to think simply transfusing FFP will minimise someone's bleeding risk prior to a procedure if they have a mildly elevated INR. That being said, if they're on medications that will prolong the INR due to a vitamin K antagonist, then the surgery could be delayed, vitamin K administered if at all possible. And if not, then there are alternative methodologies that could be considered. But there was very nice studies, which I'll show you just on the next page, where if I draw your attention to this study here, they were looking at the actual efficacy of issuing FFP to patients who had slightly prolonged INRs. So the case study that they talked about, they had 120 patients. They were issued about 340 units of FFP, and the inclusion criteria was an INR between 1.1 and 1.8. And these patients were all to have undergo radiological minor procedures. And what was really interesting in this cohort of, be it 120 patients, less than 1% actually returned their INR to 1.0, and the average reduction in their INR went down by 0.07. So not a clinically significant reduction despite 300 units or more than 300 units of FFP being used in these patients. So I think the key take-home messages from this group is you should undertake a comprehensive bleeding assessment, and just giving FFP will not reduce a patient's bleeding risk if they've got a mildly elevated INR. So I'd like to thank you all for joining me, and I hope I've made you just stop and think what else can you do to make every single unit of red cells or other blood products that you prescribe count. And I hope you remember to try to minimise, you can change your practice and your colleagues' practice by minimising these low-value healthcare practices, particularly in transfusion, not to transfuse perioperatively red cells to treat reversible causes of anemia prior to surgery. Don't transfuse red cells for iron deficiency if there's no hemodynamic instability. Don't transfuse more blood than necessary. Ideally go with a group and screen rather than a group and cross match if appropriate, and don't transfuse standard doses of FFP for mildly elevated INRs. So hopefully with your help and these top 5 recommendations for low value transfusion practices, we can have a better use of limited resources through informed evidence-based decision making and ultimately deliver our patient better care. So I've got two questions that have come through on the chat, which I might just address now, if that's okay. So for recommendation 2, it needs to be spelled out that tachycardia is a normal response to anemia and not indicative of cardiac instability. So I would agree. The reason why we would transfuse somebody red cells is to improve their oxygenation. And so I think part of identifying what signs and symptoms a patient has of anemia should really be not guided by one single trigger. So your comment of not just basing a compensatory tachycardia as an indication for clinically significant or hemodynamic compromise is important, just the same as we wouldn't take just hemoglobin alone as an indication, nor blood pressure alone or respiratory rate alone. So I think it does come down to don't take anything in isolation and look at the patient's full clinical picture. And you're exactly right, it is a normal compensatory mechanism to have a tachycardia to anemia. And then we've also had another comment about how can we encourage people to think about tolerance of anemia rather than acting on a trigger of 70. And I think, thank you for your comment, Catherine. I think it's really coming down to that same comment I made before. Why are we transfusing somebody? It's not about a trigger per se, it's about how the patient is managing and coping. We've all seen patients who, so say they have iron deficiency, who, I've had pregnant women who come in with hemoglobins at significant levels in the 50s and 60s, and they don't really say they feel any different even after we give them iron over a couple of weeks. However, after they have the baby, they definitely recognise they weren't as well as they could have been otherwise. So the body has great capacity to compensate. Iron deficiency is usually a chronic process where there are lots of compensatory mechanisms. However, rapid falls in hemoglobin is usually when patients are particularly symptomatic. But with a normal marrow and normal hematinics, their body will regenerate within the coming days. And it's about being appropriate with those transfusion practices. So I hope they helped answer your question. I think triggers are just to help people start to learn how to start to mature their concepts of when we should transfuse people. And I think the triggers were really there designed for clinical trials to say that that's appropriate and you're clearly dividing between liberal and restrictive. We all know our patients are a continuum between those, and it's about our strategies. We go into critically thinking about, is this the right thing to do for this patient at this right time? And that's really the purpose behind making better decisions with the evidence we have available. And I think that's all the questions we have. Very happy to answer any other questions that might come through, but otherwise, thank you for your time, and I hope you help make every drop count.